going into the second phase of our today's webinar, and I hand over the session to Dr. Parveen and Dr. Saurabh to do the needful.
Good evening, everyone. So we are just running slightly, we are running short of time. So I'll be inviting our panelists for this panel discussion. So I invite Dr. Manish. He's consultant nephrologist and transplant physician, Saraswati Kidney Care Center, Nagpur. Dr. Manish, is he here?
Yeah, thank you, madam. Yeah, I am here only.
Yeah.
Thank you.
And
Yeah.
our next panelist is Dr. Jigar. He is consultant nephrologist and transplant physician, Ahmedabad. Dr. Jigar.
Yes, I'm here.
So, and our esteemed another panelist is Dr. Deodata. He's director and consultant nephrologist at Supreme Kidney Care, Nashik, and he's professor of medicine, Dr. V. N. Pawar Medical College, Nashik. Welcome, sir.
Yeah, I am here.
Yeah.
Good
So
evening, all the panelists. I just add on to the introduction that Dr. Jigar and Dr. Manish, they are from the Indian Society of Organ Transplantation. Dr. Manish is the secretary of ISOT, and Dr. Jigar is joint secretary of ISOT. So definitely this would be again adding value to our discussion for tonight.
Thank you, sir. Thank you for
Thank you, Dr. Abbas.
And I welcome Dr. Saurabh and my co-host, Dr. Tapas. So, Dr. Tapas, we can start the session then?
Just 1 second. So I'll be just starting the today's panel discussion. Again, it would be something we would be discussing after the two major discussions. That is the one related to the clinical problems that we normally face, and the second one is the related to the navigating the critical care and nephrology and also oncology. Now, the first question that I would be asking to Dr. Jigar, I'm just sharing the questions. I have the question. Yeah, so So, Dr. Shrimali, a very relevant and often challenging scenario that we normally face in our clinical practice in oncology and the patients who are in ICU. Sometimes we get confused between sepsis and again, maybe not related to sepsis, but the presentation would be related to the disease that is affecting the kidney. Now, they are actually coexisting together. Now, how do you actually clinically distinguish between the two? Like more importantly, does this actually affect to our clinical decision and management?
Dr. Tapas, thank you for this question. And this is very relevant and practical question, especially in oncology ICU, where generally we see both the situation and frequently it coexists also. So generally in clinical practice, the approach should be the systemically using three pillars, that is timeline, clinical context, and urinary finding. So what about timeline? That is a very important clue. Say for example, for sepsis-related AKI, generally it is abrupt onset associated with hypotension, vasopressor requirement, systemic lymphoid response would be there. But on the contrast, disease-related renal involvement, such as myeloma kidney or glomerular disease or malignant infiltration, generally this would have more subacute evaluation, and generally they present with some prior renal involvement. Second part would be clinical context. That is again important. And in this hemorrhagic instability that clearly evident for the infection, that would be in favor of sepsis-related AKI. But see, malignant patients are having many of the time immunocompromised status, and again, they can have similar picture also with this situation. But malignancy with, say, for example, hypercalcemia, high tumor burden, with electrolyte disturbance in the form of that suggests tumor lysis syndrome, that suggests more of malignancy related AKI. And the third point is taste like various markers, urine examination. Say, for example, for urine examination, the urine would be bland, whereas with malignancy related part, there would be active sediment like proteinuria, hematuria, cast, they would be there. So, of course, this biomarker, serum free light chain assay, complement level, and imaging helps to define all the things. But most of the time, as we discussed, that distinction is sometimes it get influenced And in real world situation, they do coexist. That happens.
Very informative. Thank you, Dr. Jigar. Now, the second question.
So,
Yes, please.
Dr. Deodata, I want to ask, so as we know that many newer options are available, like immune checkpoint inhibitors and CAR-T, and everybody is nowadays discussing about CAR-T therapies. So, of course, these drugs are new, and there are some unique renal toxicities which we are seeing over last few years. So, as an intensivist, how should we adopt so that better monitoring can be done and early intervention can be done in these patients, especially the patients who have curative intent?
Yeah, so you asked me about two drugs. One is the ICIs and second is the CAR T cells therapy.
CAR-T.
So, as far as the ICIs are concerned, in Rushi's presentation, he gave us some information regarding the ICI related problems. But the predominant effect of ICIs, as far as the kidneys are concerned, is related to the acute allergic interstitial nephritis, as it was mentioned. Once you see the patient in the ICU and he is on an ICI, then you have to differentiate between whether the most common cause is likely, like the acute interstitial nephritis, or there is a differential diagnosis as far as the renal dysfunction is concerned. So, for example, you may have to differentiate between acute interstitial nephritis and acute tubular necrosis if you are suspecting a tubulointerstitial disorder. So when you suspect a tubulointerstitial disorder, obviously the patient will not have hypertension, patient could be non-oliguric, and the patient could be third spacing also. And the patient will not have hematuria. So you may have to differentiate between ATN and AIN. One of the other ways to differentiate is look for eosinophils and look for some systemic symptoms for interstitial disease, which does not occur in acute tubular necrosis. If the patient is having none of these, and the patient is oliguric hypertensive, then the patient could be having a glomerular issue. Like, for example, glomerulonephritis, or the patient could be having a TMA. So you have to differentiate between the onset of the disease and the clinical picture. It is vital to think about differentiate between acute interstitial and acute tubular diseases versus the glomerular disease, because the approach is totally different in the ICU. And once you have diagnosed that this appears to be a glomerulonephritis, then the course of action would be different. If you are diagnosed TMA based on the LDH and the clinical profile of the patient, then the approach is different. And if it is interstitial nephritis, then the standard of care would be to give steroids if you are suspecting that. Of course, rule out all the prerenal and treat the prerenal causes, give steroids and see what happens as far as the expected result is concerned. Now, this is about the ICIs. As far as the CAR T cell therapy is concerned, the most common problem related to CAR T cell related therapy is the cytokine release syndrome. So once you give it, maybe in a period of 48 hours, you will see that the patient has developed hypotension, and he has developed a lot of respiratory symptoms and complications related to the acute secretion of inflammatory mediators. So once you have seen such a patient who has got CRS, then obviously one has to be very aggressive in the management of CRS, because these patients, they are likely to be reversible also. So therefore, we need very aggressive management, which should be ideally be protocolized initially. But then, as it was said before, that the protocols can be changed depending on the individual patient. Proper fluid management is important, ventilatory support, treatment of all the metabolic issues, hyperkalemia, metabolic acidosis, all this is important. And then, of course, the specific management for the cytokine release syndrome is also important. If the patient is oliguric, then I would initiate renal replacement therapy much early as far as the CRS is concerned, because the prognosis is not so bad in some patients. So therefore, in the CAR T cell therapy, obviously, the most common thing is the cytokine release syndrome.
Thank you, Dr. Deodata, for elaborating nicely different type of renal toxicity. I'm coming to Dr. Jigar. Dr. Jigar, are you there?
Yes.
Hello, Dr. Jigar.
Yes, I
Yeah.
am.
Yeah. So, oncology cancer patient, they are not a group of homogeneous person. We can see different type of cancer patient, which some have bad prognosis, some have metastasis, and some they are in the early stage of disease. How do you approach a goal of care discussion when this patient they need dialysis or when they need prolonged ICU support?
Okay, so this is probably one of the most challenging and sensitive aspect in oncocritical care that we need to deal otherwise, and it goes purely beyond the just for medical decision. So the approach should be, over one side, it should be structured and it should be also individualized. So first of all, we should see for the reversibility. Say, for example, if having acute component that are potentially reversible inside like sepsis or tumor lysis syndrome, or is it a part of multi-organ failure if it is in the advanced malignancy? That depends. Second part would be to see would be the oncological trajectory. So a patient with controlled or potentially treatable malignant situation that deserves more aggressive approach, whereas in progressive or metastatic disease, we need to be more cautious about the intensity of the intervention. And the third thing would be the baseline functional status. Say, for example, that is again very important. In this, let outcome differ significantly between the previously independent patient in whereas someone who is already having chronic kidney disease. So in many cases, I we do see to have time limited trial for intensive support that includes dialysis. So we generally usually explain to the family that initial 3 to 5 days we need to see the clinical trajectory. Meanwhile, required RRT to be done, and this allows us to avoid both premature withdrawal versus prolonged futile care. So equally, the important is communication. We should avoid framing the discussion as simple yes or no decision about the dialysis. Instead, it should be a focus on the goal. What we want to try to achieve? What would be the constitute meaning of recovery from the patient? So generally, in our setting, family expectation can sometimes be different, and so alignment them with probable outcome that is really important. And ultimately, the dialysis in ICU is not just a technical part, but again, we need to see that how the prognosis would be there, how the quality of life we are expecting, and all over what are the survival part we are seeing with the stage of malignancy. So this would be the factor we need to keep in mind while deciding about dialysis in ICU.
Thank you, Dr. Srimali. And we will be taking the next question. I would be bringing the never-ending discussion. When to start? Is there any modified threshold for earlier initiation in certain complex oncologic scenarios that we have discussed today, like tumor lysis syndrome or cytokine storm? So, Dr. Devdutt, can you just bring some practical ICU perspective in the TLS or the cytokine storm? Is there anything we need to just keep in mind when we are thinking to start the dialysis? Early, late, some modification?
Yeah, so it's a very, very practical issue, and there are a lot of differing thoughts as far as this is concerned. Now, how I look at it is like this, that you have to see the patient and then decide through 2 or 3 things. Is the patient hemodynamically stable? That's the first part. Is the patient oliguric versus non-oliguric? That's the second part. And thirdly, what are the parameters, the biochemical parameters and the metabolic parameters? Put all this information together and then try and see whether there is a reversibility without intervention. So, for example, you may have a patient who has been diagnosed to have TLS in the ICU. He is hemodynamically stable, has some urine output, and the serum bicarb on ABG, the bicarb level is around 12 to 14, and the patient's potassium is say 5 to between 5 and 6. If that is the scenario, then you may try the conservative measures as far as all these metabolic complications are concerned. But here I feel that generally the mistake which is made in our ICUs is that we review the patient after 24 hours. Now, as far as oncocritical care is concerned, the review of the patient to be done more frequently. So maybe every 6 hours or every 12 hours. And once you find that the parameters are worsening, like for example, metabolic acidosis or hyperkalemia, or the urine output is not so good, then I would advise early intervention because these are highly treatable conditions and the chances of reversibility are very high. Now, if you look at the general AKI literature, then the general AKI literature has said that early dialysis is not really helpful. You look at the two studies which have been published previously. However, I feel that in onconephrology, if you have a AKI-like situation, then probably you have to think differently and one may consider early renal replacement therapy based on whatever parameters I have told you. The second important thing which we must remember is that a wet kidney is worse as compared to a dry kidney. What does it mean? Renal venous congestion is not so good. So therefore, just as you have congestive heart failure, now people are trying to define the congestive renal failure. So therefore, in that situation, if you find that the patient is third spacing, or if you find that the patient is going into fluid overload, or if you find that the patient is oliguric, not responding to diuretics, then that is the time where early intervention would be required. So I would be more pragmatic as far as introducing renal replacement therapy is concerned in the ICU as early as possible. And of course, the modality can change. If you want only diffusion as a method, then obviously the simple hemodialysis can do. But most of the time, these patients may require prolonged dialysis. So most of the literature has said that CRRT has a slight advantage over the usual hemodialysis which we offer. And in rare situations, if you look at the cytokine release syndrome, then Rishi has already enumerated what are the other therapies which we can offer. One comment which I want to make here is about the cytoswap therapy and the other adsorption therapies like, say, oxidase use. I believe that the timing of introducing those therapies is a critical issue. Many times we get a bad result because we introduce the therapy a bit late. So my threshold would be 48 to 72 hours as far as introducing the heme adsorption therapies are concerned in a cytokine storm. And especially when the patient is hemodynamically stable, and even if the patient is oliguric or requires routine dialysis, then it can be done in series also, along with the dialysis. So therefore, the timing is very critical as far as introducing the renal replacement therapy is concerned. So these are the practical issues which I can comment on in the ICU when you are managing these patients.
Thank you so much, sir. Very nicely answered. So my next question is for Dr. Jigar. So many a times cancer patients, when they present to ICU, they need some urgent oncological imaging, maybe for disease status or maybe of another reason. So how to balance the need for this immediate diagnostic need for any contrast studies against the risk of contrast-induced AKI? Dr. Jigar, please.
Okay, so this is very important and often over debated issue in ICU. So first of all, we need to understand that risk of contrast associated AKI is often overestimated, especially with the modern contrast agent. So in critically ill patient, AKI is usually it's multifactorial, and the severity of illness itself plays a large role than the contrast alone. So the decision should be indication driven. So say for example, if imaging is significantly influencing the management, so having the therapeutic advantage. So say for example, diagnosing pulmonary embolism, having assessment for tumor progression, or guiding for urgent surgical decision, then it should be not be delayed due to the fear of contrast induced nephropathy. And in such situation, usually the risk mitigation strategy should be there to prevent the contrast-induced nephropathy. That should be there. And again, we should identify the high-risk patient also. Say for having advanced CKD, human instability, or volume depletion. In that situation, the preventive measure in the form of having proper hydration, avoiding concurrent nephrotoxic agent, and using lowest isosmolar dose of the contrast agent, that remains very important. And it is also very important to emphasize that we should not initiate dialysis solely for the purpose of removing contrast, as it is not going to remove the contrast. If the need for renal replacement therapy is there, then it is different situation. And again, in ICU practice, AKI is rarely a single reason point. So attributing entirely to contrast can be a misleading situation. So the overall timely and accurate diagnosis, if it is more important, then the contrast-related injury should be kept on the second place, and we should go for the contrast review, provided it is having therapeutic advantage and having decision-making power.
Dr.
I think
Jigar, I
this
have just a follow-up questions for you. Like, in
Yes.
for a point of view, like nephrotoxicity, what is the difference of contrast between CT scan and MRI, and how should I take care of?
Generally, what
How
is
should I take care
said
of it?
that CT scan contrast, they are more nephrotoxic. If it is non-ionic dye, if it is not isoosmolar, in that situation, nephrotoxic would be high. What about MRI? MRI having contrast agent as a gadolinium. Now that issue is there with severe renal dysfunction. In severe renal dysfunction, excretion of this contrast agent is not there. So in that situation, it can lead to systemic nephrogenic fibrosis. That is an issue. Now that is not that common. The incidence of it is in 1 in 10,000 cases. It is something like that. But still, if it happens, it's a dreaded complication. So in that, so to summarize, contrast with CT scan lead to acute kidney injury, and it is more problematic with mild to moderate renal dysfunction. Whereas if the patient is on renal replacement therapy with end-stage renal disease, then contrast would not be the issue for CT scan. But for MRI, the issue is opposite. Because in that situation, severe renal dysfunction would be a problem. In a case, it will retain the gadolinium and it would be a problem. But it's okay to have mild to moderate renal dysfunction. So for CT and MRI, the situation is reverse for the as far as the renal part is concerned.
Thank you, Dr. Jigar. And nowadays we are like using class 3, class 2 MRI contrast and like gadolinium. I think it has very less incidence of
True.
nephronic cystic fibrosis. So I'm coming to Dr. Manish. Manish, for us in the ICU to keep the circuit pattern is a challenge because we cannot use heparin because of thrombocytopenia or coagulability, and it is more common in cancer patients. So in this setting, how should we try to give anticoagulant, or like how can we manage our circuit without giving anticoagulation?
Thank you, sir, for that question. So this is a commonly encountered scenario in the ICU settings whenever we are dealing with the oncology patients. So it's a balancing act between the circuit patency and the bleeding risk. So first of all, if there is coagulopathy, thrombocytopenia is there. So most of the times it is possible to avoid the anticoagulation. So if the patient is having the high bleeding risk like low platelets, high PTNR, and the possibility of ongoing DIC, so then in those, I think it is better to avoid the anticoagulation. We should try to optimize the circuit survival using the other possible methods like having the good vascular access if possible, more than 12 French catheter. Blood flow, if it is possible to keep more, like more than 150 to 200 ml per minute. And if you have the machine with the pre-dilution, where you can use the pre-dilution mode, then it also helps in prolonging the circuit survival, filter survival. And frequent saline flushes like 50 to 100 ml every 30 to 60 minutes. And sometimes we do have to accept that the circuit will live very short. It may not live up to 24 hours or beyond. So this is, I think, this should be the initial strategy. And if possible where the liver is okay and you need to give the anticoagulation, there is no severe lactic acidosis. In those patients, yes, definitely regional citrate anticoagulation can be preferred. I won't go into details how the citrate works, how the calcium is infused. This is just about the preferred modality, which we are discussing. So sometimes few people do try with the low dose of heparin, that is unfractionated heparin, because it can be easily reversed. So it is sometimes it can be used, but it should be used with the caution. The low dose is usually the half dose of the normal dose, that is the 5 to 10 units per kg per hour. If it is possible, then in that situation, if the liver is involved, severe lactic acidosis is there, and you need to keep the circuit patent, in that situation it can be used.
Yeah. Thank you, Dr. Manish. Very practical tips that we can actually apply in our bedside practice. Now, just continuing, I would be asking a very practical interface question, like no crucial thing, right? That in patients who are already on dialysis or patients with rapidly fluctuating renal function. Now, we are now planning to start or like give the next dose of chemotherapy. Now, how we will be actually optimizing the timing and the dosing of chemotherapy so that we would be ensuring efficacy, because the oncologist would be very keen on like low, we cannot compromise on the dose, we have to give it as soon as possible. Now nephrologist and intensivist will be little bit hesitant, like no, how we will be minimizing the toxicity. Now it's a very double-edged sword. So can you put some light on it?
Yes, that is a very good question, Tapas sir. I think again it's a balancing act, and we need to know the pharmacology, how the drug is cleared, whether it is from the liver or kidney. When then the how dialyzable the drug is, and when you want to give the drug, and how urgent is to give the drug. These are the practical things we should always look at: the renal clearance, dialyzability, whether the parent drug or active metabolite is dialyzable, and what is the therapeutic window of the drug. So, for example, we all know cisplatin, it is a highly renal and it is a dialyzable drug. So, here needs the major dose adjustment, like cyclophosphamide. It is partially cleared from the kidney and partially dialysable, like doxorubicin, mostly hepatic. So minimal dialysis effect will be there. So we need to know the pharmacology of a particular drug. If the drug is dialysable, definitely one should give after the dialysis. And if the patient is on CRRT, usually the oncotherapy is avoided at those times because those are immunosuppressants. But if still you need to give the drug, maybe other drugs, we should calculate the CRRT, ongoing CRRT, as in GFR of approximately 20 to 40. So the clearance should be of the drug should be of 20 to 40 when the CRRT is ongoing. If the drug is not at all dialysable, we can give it anytime because dialysis is not going to remove it. So these are the practical things we should keep in our mind. And in case of rapidly fluctuating renal functions, so that situation is usually seen in case of the recovering acute kidney injury or worsening acute kidney injury. So in that time, during those that phase, we need to see the daily urine output, the trend of creatinine. We should see the GFR and adjust the dose according to the GFR. So this, I think, these are the practical things we can definitely use to decide the drug dosage and timing.
Thank you
Thank you,
so
Dr.
much, Dr.
Manish.
Manish. So my next question is to Dr. Deodata. Sir, it's a debatable question. Many a times people are not very keen on for aggressive therapies in cancer patient, although this notion is changing with so many treatment options available. So, are there any clinical markers or some signs or trajectories which prompt us to now this is the time to step back from the aggressive support and it should be now in just focusing on the comfort care?
Yeah, that's a practical issue which we face on a day-to-day basis in any ICU for that matter, not only the onco ICUs. Now, as far as this problem is concerned, I think if we know the wish of the patient beforehand, then the decision making is very easy. So,
Yes.
if the patient has already expressed his wish or the family has expressed his wish concurrently, then the decision making is very easy because then you know where to stop. But suppose this conversation has not occurred and initially the patient had lots of hopes as far as treatment is concerned, and then you find that there is hardly any response to therapy. So then I feel that you have to assess whether what is the prognosis in the future depending on clinical parameters, response to therapy, And in the ICU, if you find that the symptoms and the signs are refractory, in spite of optimal therapy, for example, you have tried to correct the metabolic acidosis to the maximum, you have given the CRRT in optimum doses, you have done the adsorption, and the patient is still hemodynamically unstable with multi-organ failure, and you think that the response is not there, then I believe that it has to be a shared decision. You cannot, one individual should not be taking this decision. You have to involve everybody, the nephrologists, the
Oncologist.
oncologists, the palliative care people, and the patient's family. And then once it is a shared decision making, then I think it's very easy. The other thing which I would like to point out is that many times the patient develops drug related toxicity, and there is a lot of hope that he will come around and then we can, treat him again, and probably then the patient will survive. But I think in the oncology literature, there are some parameters where re-challenge is not possible. So if you find that this re-challenge of the drug is not possible and that drug is going to be curative as far as therapy is concerned, then it is a futile treatment, because then you can't really give the drug when it is essential, but at the same time the patient is not recovering. So all these points have to be considered when you take a decision as far as comfort care is concerned or a tender loving care is concerned.
Thank you, Dr. Deodatta. So I would say this is very engaging discussion. Thank you all our esteemed panelists for those insightful perspectives. Truly enriching session.